Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Good afternoon, everyone. This is Wayne Callan for Attitude Magazine. Today, we are happy to have Dr. Larry Silver. He is Clinical Professor of Psychiatry, retired, at the Georgetown Medical Center and author of The Misunderstood Child, as well as Dr. Larry Silver's advice to parents on ADHD. His most recent books include two co-edited with Dr. Frank Klein, intended for general education teachers. They are called Educator's Guide to Medical Issues in the Classroom and The Educator's Guide to Mental Health Issues in the Classroom. Dr. Silver was acting director and deputy director of the National Institute of Mental Health. He was also professor of psychiatry, professor of pediatrics, and chief of the Division of Child and Adolescent Psychiatry at the Robert Wood Johnson School of Medicine. For more than 40 years, Dr. Silver's work has focused on the impact of neurologically based disorders on young lives. Dr. Silver is a longtime contributor to Attitude Magazine. You can find all of his answers to your many questions about managing ADHD on attitudemag.com, as well as 12 years worth of features on everything from anxiety disorder to dads and ADHD. As always, this webinar does not constitute medical advice. Always see your doctor about your condition. Let's get started. Thank you very much, Dr. Silver. We're grateful for you joining us today.
Thank you. ADHD is a neurologically based disorder. What we mean by this is it has to do with how the brain is wired and functions. When we have neurologic-based disorders, sometimes they're due to different wiring of the brain, and sometimes they're due to changes in the impact of certain chemicals in the brain called neurotransmitters. We've known since the 1960s that ADHD is due to a deficiency of a specific chemical or neurotransmitter in specific areas of the brain. It was for this reason that we discovered that certain medications can activate areas of the brain and cause it to produce more of this deficient transmitter. And then once the level gets up to where it belongs, the symptoms disappear and the child or adolescent or adult begins to function normally. Once the medicine wears off, the level drops again and you go back to the behaviors. So perhaps you've noticed this with your family. About an hour after you give the medication to your child, he or she is calm, focused, perhaps less impulsive, and you don't need a clock to tell you when the medicine wears off because the behaviors return. Since this is genetically based, we have the understanding that there's a change in the chromosome, which is the part of the body that maintains these genes, and that in about 50% of cases, this problem is due to an inherited pattern, so it runs in families, and the other 50% we really don't know why it occurs, but it does occur. Now, what we also know is that if a particular area of a gene, which is part of the chromosome, is impacted on, it might impact on other areas. So sometimes if you have ADHD, you see evidence of other problems. And we call this comorbidity, which means that if you have one problem, you're very likely to have one of the other problems. So we know that about 50% of individuals with ADHD, they will have one or more of these other neurologically based conditions. The 50% has to do with the genetics we just spoke about. They may have an emotional regulatory problem, that is your son or daughter, or you as an adult with ADHD might have problems regulating emotions. So you may have more difficulty with anxiety than others, may become depressed, may have trouble with anger control, or may have trouble regulating thoughts and behaviors called obsessive-compulsive disorder. Other comorbid conditions, that is, conditions frequently found with ADHD, would be a tic disorder, which is a sudden contraction of muscles, or a learning disability. These conditions that we're going to describe in more detail, these comorbid conditions, are also neurologically based, that is, has to do with how the brain is wired. They also show a chronic and pervasive history if they're present. If they're emotionally based, they would start at a certain time and occur in situations. For example, if your fourth grader who has ADHD is struggling in school with reading or writing or other aspects of learning, and you think about it and realize that he or she had the same problems in third grade and second grade and first grade, and perhaps some difficulties with early skills in kindergarten, that is, it's chronic, and that it's pervasive, and that it doesn't just occur in the classroom, but there are also difficulties doing certain activities or sports, then we begin to think it's neurologically based, and it's one of these comorbid conditions. If it starts at a certain time or only occurs in certain circumstances, we begin to think it's emotionally based. So if the classroom teacher says that your son or daughter is very calm and focused most of the day, but whenever they're doing math, they suddenly become fidgety or interrupt or have trouble staying on task, or they do well in school until they have to do independent reading, but all other times are doing well, then you have to start looking for another issue, which might be a learning disability. And again, it would not be chronic or pervasive, but would start at a certain time or occur in a certain circumstance. Another example is if there's marital stress and over the weekend or evening there's a lot of tension between parents. On that particular next day, your daughter or son might go to school anxious and have trouble staying focused or be fidgety. But in this case, it would only occur on certain occasions, which are the days after there's been stress at home, and would not occur on other days. It's important to understand this concept of comorbidity, meaning that if you have one neurologic disorder, there's likelihood that you will have others, because this means that your family doctor or pediatrician or psychologist or social worker, whoever it is that's helping you think through that you have ADHD or your family member has ADHD, once you've established that, it's critical to look for one of these other conditions. If there's a 50% likelihood they might exist, then we can't afford not to see it. So the most common one is we see a child with ADHD, treat them with medication, and they're now able to sit and focus, but they're still doing very poorly in school because we've missed a comorbid situation, which is called learning disability. Or the anxiety everyone considers as part of the ADHD, but after we treat the ADHD, it continues because it is also one of these comorbid conditions. So it's important to understand this. So if you think your son or daughter or your spouse or partner or you might have one of these comorbid conditions, after the doctor has said you have ADHD, it's important that you speak up and explain this concept, let them know about this possibility. Because it's possible that especially family physicians, such as pediatricians, family physicians, general practitioners, might not know about this comorbidity issue. The one group of physicians who are more likely to know would be your child adolescent psychiatrist or your general psychiatrist. So it may be important for you to bring this up and to ask them to think about it, and perhaps give them some literature as you can get from Attitude Magazine.
Well, thank you very much, Dr. Silver. We have loads of questions here from the participants, so I'm going to start. One mom and wife writes, "My husband has ADHD and anxiety disorder, so do both our children. As a parenting partner, he doesn't understand the negative effect on anxiety has on ADHD symptoms when it's not treated. He believes anxiety meds are optional, ADHD meds are not. How can I get him to understand this belief hurts our children's performance in all areas, as well as his own?"
It sounds like you've done a good job of attempting to explain it, and you might need someone to help you. So with your husband's permission, I would speak to the physician prescribing the ADHD medication and explain the concept of comorbidity. You can refer them to the website for Attitude Magazine or to other sources if they want to read it, and get the support of the family physician who could explain that since the anxiety is there all the time and occurs in all circumstances, it is also neurologically based, and it's probably related to the same reasons they have ADHD. So that whereas you have no credibility, the family doctor might be useful. That would be my recommendation. You can give them literature to read, but he's more likely to say that doesn't rely on me. Okay.
Nancy writes, "My granddaughter has ADHD and she is on medication. She is behind her peers in school. She cannot retain anything she has learned. Is this part of ADHD? And how can I help her?"
Yeah, I'm glad you're concerned about your grandchild, and sometimes it's a little difficult getting the parents to hear you. But since there's at least a 50% likelihood that your grandchild with ADHD might also have a learning disability, I would discuss this with the parents. You can give them some literature from Attitude magazine or one of my books to support it, and then would encourage the parents to go to the principal of your grandchild's school and say that there's a high likelihood that he or she might have a learning disability along with their ADHD and request testing. If you say this to the principal, then the principal's obligated to pull together a team and at least assess this possibility. Now, in some schools, they won't consider it until after third grade, but they should take a look at it and do some testing that would either document that your grandchild also has a learning disability or document that he or she doesn't, which means you have to go looking for an emotional theme or other possibility. One of the more common other possibilities is that the ADHD caused so much difficulty, let's say in first grade, they never really learned the basic skills of reading. So now in third grade, when they should be doing reading comprehension rather than just sounding out words, they're having difficulty, and you have to go back and reteach the first grade skills. But I would talk to the parents about it, encourage them to talk to the teacher and the principal. And if that doesn't work, then you might want to go to one of my books to look at what you can do to request something under what's called a Section 504 of the Americans with Disabilities Act, which says that if someone has a disability, you must evaluate and treat it. Okay?
That's good advice. In terms of learning disabilities, how many different types of them are there?
When we look at learning disabilities, we look at them in two ways. One is what skills they might impact on, and we talk about a reading disability, a writing disability, a mathematics disability, or something called an executive function disability. If we look at any of these, we're looking at a child who is significantly behind where she or he should be for their age and grade. So a reading disability might be a fourth grader who's still having trouble decoding and sounding out words, or might still have trouble comprehending what they've read, or it might be a middle school student who can read and understand and comprehend it, but they don't retain it. They read it and understand it, and 2 days later they've lost it, so they're having trouble storing what they've learned to read. So if it's a disability, then we see it beginning to impact on their skills and how they're going to be using it. So we break learning disabilities down into reading disabilities, writing disabilities, mathematical disabilities, and something called executive function disabilities. I just mentioned reading disability. A writing disability might have to do with the motor or mechanics aspect of writing, just getting your hand to write the squiggles the way they should be, so that they write very slowly with a lot of difficulty. And the next type of a writing disability might be with language of writing, which would be spelling, might be grammar, punctuation, might be capitalization, but just getting the thoughts down on the page. So we're looking at their ability to produce the writing, their ability to write what is important, the ability to retrieve the information to get the writing on the page. Math disability is a little harder to define, but basically we just say that a child who's not mastering the math skills they should have for their particular age and grade. There's an area called executive function disorder that's not uncommon with ADHD and is considered a type of a learning disability. This is the ability to be the executive officer of your brain, the ability to organize information and to produce it in a timely way. So if the teacher gives an assignment, the ability to organize how you're going to do the assignment. I need to open up my book to a certain page. I need to look at the worksheet. I need to fill out the information and put it on the right column. I need to finish it in a timely way and turn it in. So that's the executive function part. And the timeliness is that you're able to pace yourself so things get done on time. So we talk about a reading disability, a writing disability, a math disability, or an executive function or organization time planning disability.
Okay. There are loads of questions about anxiety and ADHD. One mom writes, since anxiety may present with many of the same symptoms of ADHD, restlessness, impulsiveness, inability to sustain attention, jumping around in conversation. How do you tease out the correct diagnosis?
It's a good question. And if the problem is due to anxiety, it usually starts at a certain time or only occurs in certain circumstances. The child shows no evidence of anxiety except when they're taking a test, except when they are called on to answer a question, except when you leave the room and they have to finish doing their homework by themselves. So it starts at a certain time and occurs around certain circumstances. So the circumstance might be when they have to write answers, or it might be when they have to read information and understand it. So anxiety usually relates to a task that makes you feel uncomfortable or anxious. With ADHD, it's got to do with how the brain is wired and functioning. And so the behaviors that might look like anxiety, such as fidgety restlessness, inattention, are chronic and pervasive. They're there all the time and they occur in all circumstances. So that's the way we try and tease it out. If I'm talking to a classroom teacher and they tell me that Mary has trouble staying focused and getting her work done and sort of restless, I usually start asking questions. And when I discover that it's usually when she's doing independent work, she has to sit at a desk and read and write, but she has no trouble when there are group discussions where she leads a discussion and she's very active and raising her hand and answering questions. I have to start thinking about anxiety related to reading or doing independent work. If the teacher says that she has the same behavior, whether it's group discussions or written work or art or music or any activity that is pervasive, then I have to start thinking of attention deficit hyperactivity disorder. So the theme you're going to hear throughout this webinar is that if it's neurologically based, such as ADHD, it's got to do with how the brain functions, and the brain's wired differently. So the behaviors we're observing are chronic and pervasive. They're all the time and occur in all settings. Whereas if they're due to anxiety or depression or an emotional issue, they're there under certain circumstances and occur only in certain times.
Okay, one more question. A mom writes, my child has generalized anxiety disorder and ADHD. We struggle to control it. Intuniv, the drug Intuniv has helped, but not enough. What else can we use? His stimulant is not the problem, for his anxiety is less when he takes it.
Well, if your child has ADHD and the ADHD makes him or her feel anxious under certain circumstances, which may relate to school or home activities, so it occurs at certain occasions, then we begin to think of anxiety as the main issue. If it's a generalized anxiety disorder, which is one of these comorbid conditions we're talking about, then very much like ADHD, the anxiety is also chronic and pervasive. It's there all the time and occurs in many situations. If they have general anxiety disorder and ADHD, you need to treat both. So Intuniv treats ADHD but not general anxiety disorder. And you may want to talk to your family doctor or get a referral to a child adolescent psychiatrist to look at whether you need medication for a generalized anxiety disorder in addition to treatment for the ADHD.
That's good advice. An adult with ADHD is asking about depression. He asks, does it come from the frustrations associated with ADHD, or does it occur simultaneously?
Again, we go back to the history part. If the anxiety or depression, in this case you're talking about depression that you're referring to, is chronic and pervasive, you stop and think, I remember being depressed for a period of time in third grade and fifth grade in high school. This is not a new experience for me. And it's pervasive in that it just suddenly occurs. There's no trigger for it, and it might just as quickly go away. If it's chronic and pervasive, you have to think that the depression is one of these comorbid conditions and maybe need to treat it independent of the ADHD. If the depression starts at a certain time or only occurs in a certain situation, so you have ADHD that you've had since childhood, but you just had a relationship problem or a work problem and suddenly you find yourself depressed, so it began at a certain time and only occurs in certain circumstances, then we don't think of it as neurologically based but situational. And often cognitive behavioral therapy or other forms of therapy will work as well as medication, or sometimes you'll use medication short-term just to help you stay functional in the work situation while you work on solving the issues. So the theme you keep hearing is if you're depressed, and you remember being depressed off and on all your life, and it has nothing to do with trigger situations, you have to think of the neurologic theme and approach it differently than if it just started at a certain time or only occurs in certain circumstances.
Another question from an adult with ADHD about depression. At age 33, I was tested for ADHD and found to have moderate to severe combined type ADHD, but also anxiety and depression. The psychiatrist I talked to wanted to treat the anxiety and depression first to see if that would also deal with the ADHD symptoms. But after a very unpleasant experiment with antidepressants, I'm no better off. Can you tell me what to do?
Yeah, I understand what the prescribing physician was thinking of, and that is maybe the ADHD behaviors are because of the anxiety or depression, so let me treat that first. That is, one is the fire and one is the smoke, and if I put out the fire, the smoke will blow away. So we'd try to treat the anxiety or depression, and if the ADHD behaviors disappear, you know they were just due to the anxiety that you were experiencing. If you get a chronic history, though, that is, you report that you've been hyperactive or distractible or impulsive since early childhood, and you've had bouts of anxiety or depression only in adulthood, then I would really encourage the physician to treat both, or maybe even to treat the ADHD first and then move on to treat the others. The other difference, if you have ADHD, besides clarifying whether it's chronic and pervasive or just started at a certain time, is if you're 33 and you've had ADHD for 30 plus years, there are probably lots of emotional issues that go along with your insecurities or your lack of success or your difficulty with peer relationships, and that might be causing the anxiety or depression. But once again, if the anxiety and depression is a comorbid condition, like ADHD, it will be chronic and pervasive. Whereas if it was situational, it had to do with a work task or a relationship problem, it would start at a certain time or only occur in certain circumstances. So short answer, yes, it might be useful to treat both and clarify what's going on.
Very good. Many questions about ODD. Here's one from a mom. My daughter is 17. She was diagnosed with ADHD when she was 4 and ODD at 15. She refuses to take medication or even talk about medication. I can usually get her to calm down and talk about the situation, but if I'm not around, then things just explode or people just ignore her because they can't handle the outbursts. I don't know what else to do. Her conditions have affected her ability to excel in school, her ability to handle relationships, and decision-making. Can you give me any advice?
Yeah. You mentioned the ADHD since age 4, and the only comment is she still being treated for it, rather than thinking that you outgrow it and you don't need it anymore. And also to think about the comorbid conditions. Might she also have, say, a learning disability, and that might be contributing to the frustration. Oppositional defiant disorder is an attempt to control frustration and anxiety. That is, if I can generalize, if you have a conflict, which might be with relationships, might be with academic performance, might be with getting along in the family, there's several ways you can handle it. One is to internalize it when you feel the anxiety or depression, and the other is to externalize it, which means that you begin to handle your problems by defying people around you. So you get into this oppositional behavior, power struggles, negativism. And so what you probably need to do is see a mental health professional to clarify what is it that makes her oppositional and defiant. Is this a 17-year-old trying to deal with independence, insecurity? Is it a power struggle? Is it a spin-off of years of ADHD and possible learning problems? But it is important to do something about it. That is, if stress builds up with someone, emotional stress, you can handle it by becoming anxious or depressed, which are ways that you feel it on the inside. If that gets too uncomfortable, what teenagers sometimes do then is to externalize that stress. So rather than feeling anxious or depressed, they deal with their problems by saying, I'm fine, there's nothing wrong with me. It's mom's fault, it's dad's fault, it's the teacher's fault, it's my friend's fault. And they get into power struggles or looking for problems outside of themselves rather than inside themselves. If someone is anxious or depressed, then often they're readily available for getting help, and some counseling will work. If they've reached a point where they're beginning to say it's everybody else's fault, not mine, there's usually no question but you need some psychological help. So I would talk to your family doctor about finding a good mental health professional and have that individual work with you to see if you can solve the problems.
Okay. One dad writes in, how do you know if anxiety is not a symptom of the stimulant as opposed to a comorbidity?
Again, the common theme is if it's neurologically based, which is comorbidity, it's chronic and pervasive, begins early in life and is there all your life. So in different forms, you had similar problems in elementary school, middle school, high school, post-high school that you're having now. And the chronic and pervasive is what tells you the anxiety is also neurologically based. If it's situationally based, then it starts at a certain time or only occurs in certain situations. So you're talking about it only starting at a certain time, that is probably 45 minutes after you take your stimulant medication, and occurs in certain circumstances, that is whenever you're on medication, and when the medicine wears off, the anxiety drops. So in this case, I would see it as a side effect of the medication, and I would talk to the prescribing physician about considering a different medication.
Here's a question from a concerned mom. Does social awkwardness qualify as a comorbidity?
That's a good question. Not in its general sense. It is the child who has difficulty with peer relationships or getting along with others or being immature. We usually see it as perhaps a spin-off or a consequence of years of not doing well because of the ADHD and possibly learning disabilities. If the social awkwardness is much more chronic and pervasive, you've got an 8 or 9-year-old, but you remember this happening in preschool, kindergarten, first grade, second grade, third grade. It's chronic and pervasive, and that it occurs with aunts, uncles, cousins. It occurs with kids they know in school or when they're playing sports or in all settings over the summer. Then you begin to look at whether there may be other things involved, such as an anxiety disorder or depression. We do find that many kids with ADHD, and I can't give you an exact percentage, might also have trouble picking up body language clues. They don't read the look on the face or the tension of the body or the hand-fist behavior that says you're annoying someone, back off, which most kids can do. And they just keep going along until people get angry with them. That's a different kind of social awkwardness, and you find it again neurologically based, we believe, therefore occurring in many situations and many times. If after hearing this you're still not clear which one it is, then you might want to start with your family doctor and perhaps have the family doctor refer you to a mental health professional who works with children to help you tease out what's going on.
Another dad writes, what medications are best for a child with ADHD and an anxiety disorder?
Okay, lots of good questions. Sometimes the stimulant medications that treat ADHD will exacerbate or make the anxiety problems worse, in which case we then have a problem as to how we're going to handle it. And sometimes we use medication for the anxiety, and the anxiety level drops, but the child or adolescent or adult continues to be hyperactive in attention or impulsive or have organization problems, and therefore we're worried about what to do. In that case, when I'm not clear, what I've done with patients is to start by treating the anxiety disorder using one of the anti-anxiety medications. Now, if many of the ADHD behaviors were due to the anxiety, the fidgety, restless behavior, or the inability to focus, then we'll see improvement. If the ADHD is independent of the anxiety problem and is still there, I would then add a stimulant as a second step. That is, to summarize, if I start with a stimulant, I might stir up the anxiety. But if I start by treating the anxiety, if anything, I can make things better. And I've sort of, if you will, blown away the smoke so I can see what fire is left. And I can clarify how much is ADHD and how much was due to the anxiety. So the protocol I've always used and the literature recommends is to treat the anxiety first. And then if the ADHD behaviors are still there, to use medication to treat that.
Okay. There are several questions about tics. Does ADHD medication bring out an underlying tic disorder?
People asking these questions must have read my book. Yeah, the more common situation when you go on medication and the tics occur is that the tic disorder was there but not clinically present yet. It's one of those comorbid conditions we list. And so the stimulant medication brings out the tics. In that case, we have several choices for treatment, but let me continue with the first thing. If you put someone on an ADHD medication and they're now able to sit still and pay attention at work or in classroom, which then begins to show their underlying other comorbid problem like learning disabilities, then the learning disabilities, they make them anxious and trigger the tics. Sounds a little confusing, but if you have a learning disability and ADHD, it's so easy to say it's the ADHD making the child not able to learn. And so you treat the ADHD and the child is left with the learning disabilities, but you've taken away your rationalization for why they're having trouble with learning, and you have to begin to address that, and that stirs up the anxiety. Another way of looking at your question is that if you have a tic disorder, it can be obvious or clinical when it's present, or it could be subclinical, or you have a predisposition to it. And it's only under stressful situations that the tics come out, and then the stress is relieved and the tics may go away. Your decision to treat the tic disorder depends on how much it's interfering with life and how much you think it would be useful to suppress it or keep it from being a problem.
Very good. One mom writes, what can be done with a comorbid ODD and ADHD diagnosis? Can these symptoms, I think she's asking about the ODD, be exacerbated with lack of sleep?
I'm going to take the easy part first. Any emotional problem, whether it's neurologically based or situationally based, gets worse with lack of sleep. As you know, if you're having trouble with a relationship and you're upset and annoyed, when you're rested and comfortable, you can kind of manage it and not lose your temper. But if you're tired or exhausted, you're much more likely to just blow a fuse or let it out. So yes, the sleep issue might be there. The first part of that, I think, was the ODD part, oppositional defiant.
Yes.
If a child or adolescent, and for that matter adults, except we use different terminology, but if a child or adolescent has an emotional conflict, whether it's got to do with a relationship or something going on in their own head or something else going on in their life, some will internalize it, they keep it inside, and because of that, as I mentioned earlier, it can make you anxious or depressed, and so what you see is the anxiety or depression. And then when you start working with this individual, you begin to find out what it is that made them anxious or depressed. Some find it easier to externalize it, that is, to project the cause onto someone else. It's not my fault, it's my mother's fault, it's my sister's fault, it's the kid on the school bus's fault, it's the teacher's fault, it's the principal's fault. If it's an adult, it's my co-worker's fault. And the value of blaming someone else is that therefore you don't necessarily feel the anxiety or depression because it's got nothing to do with you, it's someone else. So with children and adolescents, if they keep their problems inside themselves, we begin to think of an anxiety disorder. They're anxious because of it, or a depression because they're getting depressed because of this problem, or there's some somatic or physical symptoms may develop. If they externalize it, no matter how bad life is, it's the other kid's fault, it's the teacher's fault, it's the parent's fault, it's always someone else's fault. and they don't feel the anxiety or depression. Then we call it oppositional defiant disorder. They're blaming everybody else. It's very difficult to treat because you have to work hard to help them begin to put up a mirror and look at themselves rather than to point to other people. But the oppositional defiant disorder then is often seen more as your way of coping with the problem than as a neurologic problem in and of itself, even though I'm going to put in parentheses that's a debatable topic right now in psychiatry. So if someone has oppositional defiant disorder, which means they're blaming everybody else and don't take any ownership for their problems, you probably need to see a mental health professional to get some help on dealing with it first as a family. What we do is try and teach parents to hold up mirrors, if you will. That is, every time the child says, you did something, or my brother or sister did something, the mirror is saying, I guess it's so much easier for you to blame me than look at the possibility that you're having trouble. And so we have to begin to hold up mirrors and keep reflecting back until we can get our child or adolescent to say, gee, maybe I am part of the problem, and then you can begin to deal with it.
Here's a question about sensory integration. My 9-year-old son has ADHD and sensory integration challenges. I've read that occupational therapists treat sensory issues. My confusion is, what should we focus on first?
For those who are not familiar with sensory integration disorder, many of us believe that it's a neurologically based disorder and it's on the comorbidity list. And what it means is the child may have trouble correctly interpreting visual inputs, which are more easy to recognize because they're confusing positions in space in terms of where they are or what they're seeing. They might have trouble with vestibular, that is the inner ear balance mechanism. Tom, you very commonly see that as going up and down stairs. Going upstairs is easy. You just lift your foot and let it drop until it hits the floor, and then you stop and lift the other foot and let it drop. But going downstairs is very different because as you move one foot forward, your head tilts. And unless you can get your inner ear vestibular system to say, hey, stupid, you're going to fall if you don't arch your back, and so you arch your back. They're not that nasty, but anyhow, you've got to compensate for arching your back as you go downstairs. Unless that vestibular system is functioning, kids feel very insecure going downstairs. And so they'll hold on to the railing. They'll take one step at a time. So sensory integration is, I feel, a comorbid condition with ADHD, and it has to do with some visual perceptual problems. With these vestibular problems, the ability to know where you are in space and to balance and adjust. And the third behavior that goes with it is tactile sensitivity. So you may have a child who doesn't like to be held or touched or cuddled, and you found that you can't just lightly stroke their skin. You have to, if anything, squeeze hard and get down to the muscles feeling the touch as well. Now, there are some professions, and to a degree, some of the pediatricians don't believe in sensory integration disorder, and they see it all as emotional. As a former pediatrician, male child adolescent psychiatrist, I need to say I disagree. I think the literature is very clear about sensory integration disorder. For those who've never heard the term, if you get my book, The Misunderstood Child, there's a section in there that goes into more detail, or you can type it into your computer and you'll get some information on it.
Another parent writes, my son has difficulty with math and writing, but the bigger issue is motivation, finding a way to encourage and support him in classwork and or homework. His typical response is skipping school, so he doesn't have to deal with the challenges of learning. Do you have any advice?
Well, skipping school was probably the third or fourth level attempt to deal with the problem. And my general advice before I become more specific is to blow away the smoke and look for the fire. That is, the issue is not skipping school or not being motivated to do homework. The issue is, what is it about the school environment that makes them not want to be there? Or what is it about completing their homework that makes it difficult to do that? So I would encourage the mother or father to step back and observe, meet with the teacher, meet with the principal, and try and understand the cause. I always say, let's blow away the smoke and take a look at where the fire is. What you may discover is that he or she has had trouble with learning, with reading or writing or math or organization, and then they've gotten to the point of frustration where they don't even want to be in school. So I'd want to make sure that wasn't clarified, or they may have had ADHD that was never treated, so they've had trouble staying on task or staying organized or being able to deal with executive function or organization skills that are so critical in middle school and high school. So I would start with skipping school, which means school is too stressful to be there. And you probably are going to need someone to help you with this. You might start with a school counselor, or you might bring in a mental health professional. But you need to clarify whether they're skipping school because of interpersonal problems, peer problems, whether they're skipping school because of academic stress, whether they're skipping school because they have other emotional problems that are interfering with their ability to be in school. But either way, I would take it very seriously. If you haven't done it yet, would start the meeting with the principal, bringing in the teacher and the school counselor, and then if you still need to bring in a mental health professional to help you think it through.
There are lots of questions today on medication. One parent writes, how safe are anxiety medications for children? My son is on a low dose of Risperdal, but a pharmacist was warning us against it. I have more faith in our psychiatrists than the pharmacists, so we have kept him on it. But it does concern me. What is your feeling about that?
Okay, my first comment is Risperdal is not an anti-anxiety medication. It's used for a very different reason. So you might want to sit down with the prescribing physician and clarify. We don't treat anxiety disorders with Risperdal. If the anxiety is due to other problems, a psychotic disorder or autism-like disorder or many other disorders, I don't mean to say that the person asking the question has a son or daughter with those two, but it usually is used to treat disorganized thinking and psychotic-like behaviors. It is not used for treating anxiety. So my best answer I can give is go back to the prescribing doctor. If the prescribing doctor is your family doctor or a pediatrician, then you might want to say, you know, this is a pretty significant or potent psychiatric medication. Do you think I should see a child adolescent psychiatrist in consultation? Just in parentheses, if you went to your pediatrician and your child had a lot of problems with asthma, they may send them to a specialist with pulmonary disease. If they have trouble with joints, they might refer them to an orthopedist, etc. And if they're having significant, in this case, it's significant if they're on Risperdal, emotional problems, they should see the physician who works with these problems, which would be the child adolescent psychiatrist. But I would share your concern and encourage you to get this consultation.
Another parent asks, how can you distinguish between inattentive ADHD and bipolar disorder?
On the surface, it's a little difficult, but let me see if I can answer that. Inattentive ADHD can take two forms. The least common one is difficulty staying on task or being attentive. You're easily distracted by things in your environment. And that was our original way of looking at the D of ADHD. We've learned much more and begin to see that in most cases the inattention is due to what's called an executive function disorder. The ability to be the executive officer of your brain, to organize and make plans and carry things out in a timely way. I've got a book report due on Friday. If you have executive function problems, one possibility is you just don't time things properly, and then you're up all night Thursday night trying to put something together. So executive function disorder has to do with organizing, time planning, carrying out tasks. It's time to straighten up my room. How do I organize information and put it away? So it might be the problem is their bedroom is chaos, and no matter how many times you tell them what to do, they just can't get themselves organized to carry it out. So inattentive ADHD used to refer primarily to someone who's having trouble maintaining focus on what's going on around them. The more recent research suggests that the inattentive part has to do with executive function problems with organization and time planning, and therefore a medication can help working with a tutor, or if you're an adult, with a coach who helps you with the organization problems can be helpful.
And bipolar disorder, what would be some of the...
No. The clear picture of bipolar disorder with children and adolescents is still trying to be teased out. We think we understand it, but we're not sure. But it usually relates to shifts in moods. The most common one is for the child to be depressed over a period of time with occasional blips of rage or anger that can go on for 5 minutes, 10 minutes, 15 minutes, and then it's over. But you can also have children who can either be deeply moody or very explosive during any time. With inattentive ADHD, the main problem is organization and time planning. You don't get the anger outburst that you would receive bipolar, and you may not get the depression. So that would be the way I would tease it out. And if your prescribing doctor is having trouble teasing out the two, then once again you might want to see a child-adolescent psychiatrist to help you work that out. The other clue is bipolar, like ADHD, is heavily familial. And so if you see yourself or your parents or your brothers or sisters, aunts, uncles, grandparents who've had similar problems, and they've been diagnosed over the years with a mood disorder or bipolar, that would certainly support the bipolar concept. Whereas if the long history is more people who've had trouble with inattention or activity level, then you would think more of the ADHD. If you continue to be in doubt, I would see a specialist, which in this case would be a child-adolescent psychiatrist, to try and get the answer.
That's some good advice. Is there an association between autism and ADHD? And how can you distinguish between the two of them? I think the DSM-5 made a stronger connection between the two. At least that's the way I remember it.
Autism is the inability to be able to connect and relate to significant other people, which might in the beginning be a parent or parents or other significant adults. And that's the core symptom of autism, the inability to relate correctly to significant people. In DSM-4, we broke it down into various stages, and we had something called Asperger's disorder and others. But in DSM-5, it goes back to the basic, and that is the number one criteria for being called autistic is the inability to form relationships with significant others or other. And then in addition, one might have ways of releasing anxiety through their muscle behavior, the flapping, jumping, rotating, but that's not required to make the diagnosis. And there's several other criteria. ADHD, the primary problem is either inability to maintain attention, hyperactivity or fidgetiness, or impulsivity, difficulty stopping to think before you talk or you act. And the behaviors are not necessarily present in terms of relationships. It's not avoiding relationships. It might be more in tasks where you have to perform. But autism, under the new definition, which starts with the inability to form a significant relationship with a meaningful other, which would be a parent, is the core issue, and you just don't get that with ADHD. With ADHD, it's more of a behavioral problem because of the consequences of the inability to sit or focus or think before you act. If you have a son or daughter and you're really struggling with this and your family doctor is not helpful, then I would request a referral to a mental health professional who knows children to help you tease that out.
Some parents are concerned about OCD here. One asks, can obsessive-compulsive behaviors develop as a compensation for ADHD problems caused by impulsiveness in thought or action?
A good question. The behaviors might look the same. The difference, again, is the pattern. If it's obsessive-compulsive disorder, which is comorbid with the ADHD or the learning disability, it will have a chronic and pervasive history as well. And you can go back and look at early childhood, middle childhood, maybe adolescence, depending on the age of the child or adolescent or adult. We're thinking about and see them going through rituals or obsessive compulsive behaviors. At the same time, they've had trouble with focus or attention. If the compulsive behaviors or the rituals or the obsessive thinking begins at a certain time or occurs only in certain circumstances, only began in third grade, only occurs in school when they're doing certain things, or at home when they're around a large group of people and anxious, then we have to think of it again as a consequence of emotional stress. So again, when we're looking at OCD and it's chronic and pervasive, like the other comorbid conditions, we have to think of it as a separate disorder. If it starts at a certain time or it occurs only in certain circumstances, we have to start thinking of it as smoke rather than fire, and we have to blow away the smoke and look for what's causing the fire. What's the major issue that's going on?
Okay.
If I could make a comment, the reason that the research began to look at these comorbid conditions is that as we worked with children with ADHD, and in my case I'm talking about going back to the 1960s, we began to see kids who had the anxiety or depression or obsessive compulsive disorder or tic disorder or learning disabilities, and began struggling with, is this a consequence of or cause of the ADHD, or is this a related or comorbid disability? And some of the earlier research which I was involved in really began to document, which is now very well established, and that is it's really a comorbid condition.
Okay, here's one concerned mom. Do most ADHD children have trouble with working memory? And does the best remedy typically involve medication or therapy, or a combination of both?
Working memory is usually referred to as the ability to retain what you're currently working on or learning, so that you don't, say, read a chapter in a book and you read a page and understand it, read a page and understand it, read a page and understand it, get to the end of the chapter and don't remember what you've read. And working memory is a critical part of learning. It could be due to a learning disability, and that's usually what we think of. The confusion is for the child who's very inattentive, or the adult, and you're reading a book and you find yourself having completed the chapter and you have no idea what you've read because your eyes are reading the page but your mind is someplace else. Then you begin to think of, could it be ADHD that's going on? If you're talking about a child or adolescent, I would start with the teacher and then ask the teacher to refer you to the counselor and eventually to the learning disability specialist in your particular school, and have them take a look with you as to what the cause is. There's some formal testing that will give you specific answers. This is due to short-term memory, working memory. This is due to something else, or this is due to inattention or ability to stay on task. So it's a good question, and I think you're going to have to pull some other people in to help you tease them out. The other clue, which is more obvious, is you find that it only happens on the days where the kid forgets to take their medication in the morning. So you can begin to see that it's the ADHD and the inattention involved with it that's causing the memory problems.
Very good. One dad asked, is pulling at hair, playing with cuticles, pulling hair out of eyebrows, all of these behaviors, are they comorbid with ADHD?
They can be. That's called trichotillomania, which is a fancy word for twirling hair or pulling it out. And so you might see children, adolescents, or adults with no hair or bald spots on their head, or no eyebrows and no eyelashes. Many people think it's a variation on obsessive compulsive disorder. Some feel it's an independent disorder. It's very difficult to treat. And it's comorbid with the ADHD. One of the comorbid conditions was obsessive compulsive disorder. And again, it's very difficult to treat. For some people, we do find that the stimulant medication for ADHD makes it worse, the trichotillomania. And so often we have to stay away from the medication and try alternatives for dealing with the ADHD. But if this is an adult with a problem or you're seeing it with your child or adolescent, it really is important to bring in mental health professional to help you, and often it's behavioral therapist or cognitive behavioral therapist who's successful in dealing with it.
One adult with ADHD says that he has struggled with depression ever since he can remember. Before getting the ADHD diagnosis, antidepressants made him more miserable, while ADHD meds helped him enormously. He feels he needs to take both an amphetamine and methylphenidate to be motivated. Is it safe to take both of those medications?
Let me make a general statement first, and that is it's important for the person asking the question to not be his or her own physician. We even say to physicians, don't treat yourself, see someone else. If this person happens to be one, you really need someone skilled in the area to take a look with you as to what's going on. It is possible for some people to have a very low level of anxiety or depression, which you're not even aware of, and they go on ADHD medication like a stimulant, and it exacerbates this problem, and it suddenly becomes visible as suddenly they experience the anxiety or depression. So that has to be teased out. Now the question was, should he use methylphenidate or Ritalin, and perhaps needs to understand that they're the same thing. Methylphenidate is the generic name, Ritalin is the trade name for the product. If the medication makes things worse, I would sit down with the prescribing physician and talk about it and try to tease out what's the best way to handle it. And it might be a referral to a mental health professional who understands these areas might be the most useful way to go.
Here's a question from a school psychologist. As a school psychologist, what is the best way to notify parents and teachers about comorbid disabilities?
If it's a parent, it's a little bit tricky. I mean, you can bring them in and talk about, we know your son or daughter has ADHD, and the teacher is reporting this, or this, and like anxiety or depression. And I'm not in a position to make the diagnosis because if you're a school professional, that's difficult to do on your own. Not that you're not competent to do it, but you're just the situation you're in. And I would encourage you to talk to your family doctor or have your child or adolescent see a mental health professional to try and tease it out. You might give the parents some reading material to say, it's not uncommon to have ADHD and also have the other issues. The other thought is it would be very useful to the prescribing physician or the mental health professional who's going to make the diagnosis to have the information you have. So it would be useful to do some classroom observations and to be able to say, I'm observing and this kid is fidgety or anxious all day long, not just when they're doing written work or when they're called on to speak in class, but as we're looking at that chronic and pervasive versus situational, and that can be very useful to sort out. But I'm glad this school professional is aware of these issues and helping us try and tease out what the problem is.
This is a very good question. What type of testing or evaluation should I seek or request for my son, diagnosed with ADHD combined type, to evaluate for comorbid conditions?
Well, if they have ADHD, it depends which comorbid condition we're talking about. If you suspect they have a learning disability, that is, they have a long history of difficulty mastering skills relating to reading, writing, math, organizing information, you would start with the principal of the school. Might bring in some literature to show the possibility that 50% of people with ADHD may also have a learning disability. Express your concerns and request that the principal arrange for evaluation. The evaluation takes about 5 hours. It's quite costly if you do it privately, and the school is more than capable of doing it. And the test results will confirm whether there's also a learning disability along with it. If you don't want to do that, then you need to get the name of a psychoeducational diagnostician. Usually it's a clinical psychologist, but could be others who would do the testing and give you the results, and then you would take it back to the school. The testing usually involves psychological testing, and the most common is an IQ test. Not because we want to measure just IQ, but because there are 12 parts to an IQ test, and each part requires a particular cognitive skill. And so if you start seeing inconsistencies, there are very high scores on some skills and low scores on others, it slants you to thinking there may be a learning disability. If all the scores are high or low, it makes you think it's got to do more with intellectual ability. And then the educational testing looks at whether the child or adolescent or adult, if it's adult testing, is at grade level in all skills, and if not, what the reasons might be for it. So I would sort of take it in steps. The first step would be to observe and try and tease it out. And the second test would be to get some formal testing to confirm it.
An adult with ADHD writes, are there any alternative therapies for ADHD and anxiety?
By alternative therapies, I guess, I mean other than medication.
Yes.
Cognitive behavioral therapy can be helpful for some people. It's a means of helping you think through different cognitive skills or techniques that you can use, or relaxation techniques, or there are many others that can be considered. But it's basically helping you try to deal with the stressful emotions in a healthier way, either to minimize it or to find techniques for controlling it other than medication. And often that's a good first step. If the cognitive behavioral therapy by itself is not successful, then often you can use the medications. But even there, if you're using both, you can often use less medication. So I would explore it with whoever the mental health professional or health professional is as to how to go about doing it.
One mom is asking, my 14-year-old daughter has been diagnosed with severe ADHD, bipolar, oppositional disorder, and an anxiety disorder. Her reactions to meds have been less than stellar. She lies about little things and big things, has been accused of stealing things. Any meds for ADHD have made her worse. She gets very nasty at the drop of a hat. Where do we go from here? Her doctors and therapists don't seem to have an answer.
Rather than give a specific answer, I would say that to use a parallel first, if your child had diabetes and the pediatrician is treating the diabetes through diet and perhaps medication and dealing with stress and all the other issues one would use to treat the diabetes and it's under control, that's great. If even with those approaches the diabetes is very fragile and not under control, the pediatrician would refer to a specialist in metabolic disease and diabetes because they have more skill and knowledge about dealing with these difficult cases. And the same is true with the parent who's asking here. If the pediatrician, by making suggestions, by referring you to some people doing some behavioral therapy, by perhaps trying some medication, can help your child or adolescent do better, that's great. If at a certain point things are getting worse and that's not enough, then it's useful for the family doctor or pediatrician to refer you to a mental health professional, and since medications probably will be needed, it would be referring you to a child adolescent psychiatrist who could take the next step in figuring out what else to do.
And one very challenging question from a parent, how do you discipline a child with ADHD and ODD?
With difficulty. Can I stop there? Well, with ADHD, I would ask the parent to just keep some records. It would be useful for the other behavior as well. I often ask them to do something very simple called ABC charts, and I describe it in more detail in my book, The Misunderstood Child, but you just make 3 columns on a page. The middle column is B, behavior. What is it you observed? Hit sister, gave me a hard time, didn't get along with peers, whatever the behavior is. After 10 attempts to get him to set the table, he just still won't do it. A is the antecedent, as best you can tell what might have caused it. And C is the consequence, what did you do about it? With this information, we go down the B column and see if we can clump together what the issue is. Is it across-the-board oppositional behavior or just under certain circumstances? Is it more likely to occur after 5 o'clock at night? And this is an ADHD individual who only takes medicine at 8 and 12 and it's worn off by 4 o'clock. But can we get any clues to help us clarify what's causing it? A is the antecedent. Can we figure out what triggered it? Is it more likely to occur when they first get home from school? Is it more likely to occur in the evening when they're tired? Is it more likely to occur anytime you ask them to do something? And see as a consequence what works. And it may be the parents have been inconsistent. Sometimes they yell and scream. Sometimes they send you to the room. Sometimes they're so flustered they'll just say, oh, forget it, and walk out of the room. So there's no consistency. So the ABC charts help us sort out what the cause is and whether it's occurs in certain circumstances or due to certain situations or only occurs at a certain time, which may be when the medicine's worn off or they're tired, or may occur only when a parent gets home and mom and dad begin to fight, only occur at night when there's stress between parents. What can we look at in terms of what's triggering it? And if it's due to the ADHD medication type of thing, we usually find that it's chronic and pervasive. It's not necessarily related to which parent are home or what's going on. Often we get the clue that it's when the medicine's worn off. Sometimes we get other clues. So in the situation we're talking about, the ABC chart would help us sort out, is it situational, and if so, what's causing it and what can we do about it? Or is it chronic and pervasive, that is neurologically based? And we have to look at some of these comorbid conditions that we've been talking about. And that would sort of lead us as to where to go next.
Right. Well, we'll have to leave it there. I believe we're out of time. Thank you so much, Dr. Silver, and we appreciate all your tips. Everyone, once again, please check out Dr. Silver's books. Thank you so much.
Bye.
Take care.
For more Attitude Podcast and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.